delighted to introduce both Katie and Martin. So Katie trained as a doctor and has a DPhil in women's health, and she's undertaken systematic reviews for NICE guideline production and is a systematic reviewer with Cochrane ENT. Martin is director of Cochrane UK and the founding coordinating editor of Cochrane ENT and works clinically as an ENT surgeon in Oxford. So welcome both.
Thank you.
Please start your talk.
Thanks very much, Becky, and welcome everyone to this afternoon's session. Thanks for joining us. We're going to start talking today about interpreting the results of systematic reviews. And the idea of this session is to hopefully help you as clinicians and as users of systematic review evidence to move from what are the results of this review to what does it actually mean for me and for my practice? How do I use these results in my everyday clinical work? So the talk itself is going to broadly fall into three parts. For the first section, we're going to talk about something called the grade approach, which is the system used in many systematic reviews for looking at the certainty of the evidence. So not just what the result is, but how robust is that result and how usable is it? Then in the second section, I'm going to show you some summary of findings tables, which those of you who've used Cochrane Reviews before might be familiar with, but I'm really going to encourage you that these are a very useful place to find a synopsis of the main features of a review and the main results, and a really useful, quick way of getting the gist of review evidence. And finally, we're going to talk a little bit about some key issues in data interpretation and kind of pitfalls and things that might catch you out if you're not wary when you're reading, particularly abstracts, but any data interpretation from a systematic review. So my first few slides are about the grade approach. Some of you will be familiar with this slide on the screen now, which shows us the pyramid of evidence-based medicine. So this is the idea that there is a kind of natural hierarchy in the type of evidence that we're using as clinicians, which goes from lower certainty data, things like case reports, expert opinion, up through slightly higher certainty evidence from observational studies, and then up to RCTs, and finally at the top, a sort of filtered information of systematic reviews and meta-analyses. And the idea of the grade approach is that this notion of a hierarchy of evidence can also be applied to the results of a review. So not just to the nature of the evidence that you're using, but that individual result. And the idea is that every result we see in a systematic review should be interpreted in the light of how certain that result is, not just what the result is, but how certain it is. So GRADE is an acronym. It stands for Grading of Recommendations, Assessment, Development and Evaluation. And it originally stemmed from the use in guidelines across the world, where it was found that people were making recommendations on treatment based on very variable certainty evidence. So the idea of GRADE was to produce a sort of transparent, robust and reproducible method to assess the certainty of that evidence for the end user. And it's now widely used across all Cochrane Reviews, NICE guidelines and many other producers of evidence synthesis worldwide. So GRADE has 4 levels of certainty, and the idea is that all the evidence shown to you in a review will fall into one of these categories: high certainty, moderate, low or very low. And these levels of certainty really reflect our confidence in this result being a genuine result that's unlikely to change as further evidence accumulates. So as always with a systematic review, new evidence is coming along. In 6 months' time, an extra study might be added. But GRADE is telling us something about the review author's confidence that this is a robust effect estimate and it's likely to represent the truth. So how do the review authors come up with this rating of GRADE, and what things do they take into account? Well, there are several different issues which impact on the certainty of the evidence. The first issue that's considered is what's the nature of the data that have gone into this result? So do these data come from observational studies or do they come from randomized controlled trials? Data from RCTs usually starts at a higher certainty than that from observational studies. However, it's not just about how the trial was conducted and what's the nature of the trial, but also what happened in the conduct of that trial. Are there any risks of bias in how the trial was conducted? So in a systematic review, usually that's assessed for each study that goes into the review with a specific tool. So often for Cochrane Reviews, we're looking at RCTs and we use the Cochrane Risks of Bias tool, but there are similar tools available for different types of data. So all of the studies have been individually assessed, and then you take a broad view of the studies that have gone into that analysis to look at the risk of bias in those trials. As well as the design and the conduct of those studies, we look at other aspects of the result. So in particular, we look at variation between the different trials. In a systematic review result, perhaps you'll get 3 studies, 5 studies, 10 studies which have gone into a meta-analysis. And what we're looking at is whether the results from each of those individual studies are very similar to each other, and there is not much so-called heterogeneity between them, or whether actually one study reports a very different result to other studies, and there's a lot of heterogeneity. If there's a lot of variation between different trials, then we would reduce the certainty in the estimate, and the grade level would drop perhaps from high to moderate certainty. The other things we look at are indirectness of the evidence. This is the notion that when you conduct a systematic review, you set out with a very specific question in mind. You're very interested in a particular population of people having a particular intervention compared to others. But actually, when it comes to the process of collecting the data and identifying the studies, you don't always find exactly what you set out to do. And perhaps this means that your confidence in the estimate is reduced. So say I want to do a systematic review looking at penicillin for tonsillitis in young children, children under 5. But actually the data I get from my review is in an older cohort, children aged 5 to 10. It's still probably relevant data, it's still useful data, but it doesn't quite answer the question I set out to ask. So I might downgrade the certainty of that evidence to reflect that uncertainty. Next, we look at the precision of the estimates. So many of you will be familiar that lots of results in a systematic review are reported firstly as a point estimate, but with a confidence interval around that point estimate, which represents the range within which we expect the ultimate answer, the ultimate result to lie. Now, if that confidence interval is quite tight around the point estimate with a very narrow range, we would have a bit more certainty as to the effect, as compared with confidence intervals which are very broad. So sometimes in a meta-analysis, you might have a point estimate that suggests an intervention is beneficial, but actually the confidence interval are so wide that that intervention may be beneficial, or it may indeed be harmful, in which case our certainty in the estimate is reduced. And finally, we consider the chance of publication bias. So as a systematic reviewer, publication bias is the bane of your life, because the whole point of a systematic review is that we collect all the available data and synthesize it. But we're all well aware that positive findings are much more likely to be published than negative findings. And if those data aren't published, then we often simply can't get them and include them in the review. So if this is a big issue, this would also impact on the certainty of the evidence. And our grade rating is based on these 5 things to come up with an overall conclusion for each result about the evidence certainty. Now, I draw your attention to the fact that, particularly in a Cochrane review, but in most systematic reviews you read, this grade evidence and the grade certainty is meant to come all the way through the review findings in the language that we use. So when you read a review and it states that an intervention probably results in something, or may result in something, or an intervention does result in something, what the authors are trying to do is to convey to you the certainty of the evidence. So you need to read the review in that context and notice the sort of language they're using, because they're trying to help you use these results in your day-to-day practice and understand whether these results are robust and certain or not.
I think I should just interject there that Katie has made something that's actually quite complicated seem, I think, relatively straightforward, and that's great as a teaching exercise, Katie. But as some of you probably realize, there's a whole industry built around training people to do this. And if you find yourself doing it, there are courses you can go on to learn how to do these grade ratings. It's a good thing to do. I'm sure there are lots of other ways you could rate the evidence, but this is the way that Cochrane has chosen to go. It's a way that NICE has chosen to go. So it's a good thing to learn about and get your head around. And if you want to know more about it, you can go to the grade website and you can find teaching materials and tools to do it. But it is really quite complicated, but it's built on very strong foundations, as Katie has mentioned.
Thanks, Martin. So we're going to move on now to the central section of the talk, which is about summary of findings tables. And as I mentioned in my introduction, I would really encourage you to use these when you're looking at systematic reviews, because they're a brilliant way of getting to grips with the fundamental conclusions of a review in a fairly time-efficient manner. We understand that Cochrane reviews are long, often unwieldy documents, and it's quite hard to get a quick summary. But the summary of findings table is really your friend, and I'd encourage you to use it. So I'll give you a quick example of a summary of findings table. This is taken from the Cochrane handbook, and it's an example from a review which is looking at the use of probiotics in children to prevent diarrhea. So the tables look something like this, and they contain all the information that you should need as an interested user of the review. And you can obviously go to the full text of the review if you need a bit more. So in the first columns here of the review, it tells you about the outcome. Now, obviously, our reviews often have a number of different outcomes. So this sort of review might look at the incidence of diarrhea, it might look at weight loss in the children, it might look at some kind of measure of health-related quality of life. But here I've just got one outcome to show to you, and that outcome is the incidence of diarrhea. So how many children got diarrhea in the group that received probiotics and the group that didn't receive them. In your summary of findings tables, you'd expect to see a bit more information, as is shown here, about that particular outcome. So they're telling us about the intervention that was used, what dose of the treatment was used, how long these children were followed up for, and what age they were. And at the bottom here, you can see the total number of studies that went into this analysis and how many participants were included. So 7 studies and almost 1,500 participants, so quite a large meta-analysis. Then as we move across to the central columns, and if you look at the columns that are grayed out first, these are showing you the absolute effects. So we can see in the first column there, the children who did not receive probiotics had a rate of diarrhea of about 22%. This compares with a rate of 8.9% in those who did receive probiotics. So you can directly see the absolute effects in both groups. The third column is showing us the difference. So how many fewer children would be expected to have diarrhea if they receive probiotics compared to not receiving them? So we can see from these numbers, 8.9% compared to 22.3%, that really more than half the children were saved from having diarrhea by having the probiotics. And that's reflected in the column on the left, which shows the relative risk. And often a summary of findings table should show you both the relative risk, comparing the two groups, and the absolute risk. And you can see that the numbers in bold are the point estimates. So that's our best guess of the estimate for all of these outcomes. But the confidence interval is also shown below them. So you get a feel for the range of effect. When we look at the last columns, these show you the author's summary of the certainty of the evidence. So in this example, they've rated this evidence as moderate. RCT data has gone into it, but they've considered that there's a risk of bias with these studies, and they state a footnote at the bottom of the study, at the bottom of the table, sorry, which says there's a high risk of bias due to the high loss of follow-up. So part of the grade rating is being transparent about the decisions you've made and letting other people understand why this is rated as moderate certainty. And in my previous slides, I was talking about the language used. So because this is moderate certainty evidence, the comment the authors have made is that probably probiotics will decrease the incidence of diarrhea. So I'd really encourage you to use these tables. They're present in all Cochrane reviews for the main comparisons in the reviews, and they show, if not all of the outcomes, then certainly the critical and most important outcomes of the reviews. And they can be a really helpful summary of the main results. However, we understand that many readers of Cochrane reviews and users of our reviews start and stop at reading the abstract. So we thought it's worth spending a few minutes looking at some of the challenges with reading abbreviated versions of results and just putting a few things in your head to think about when you're interpreting data to try and make sure it's useful for you. So the first thing I'm going to do is show you an example abstract here. I'll give you a couple of minutes to read through it, but really it's a made-up abstract just to demonstrate some points to you. But what I'd like you to think about when you read it is, what else do I need to know as a user of this evidence before I can be sure what these results are telling me? What else would be helpful? Where is it not clear what the data represent, what the data mean, and what do I need to know? And if we're able to use the Q&A box, so you can click on the Q&A box in Zoom, and you can put in your thoughts in there, and we'll have a talk about some of the issues afterwards. Great, we're getting some good ideas coming in. Thank you, everyone.
And Katie, we also have the first question there from Faisal relates to the summary of findings table. So perhaps we could pick that up at some point as well.
Yes, the confidence interval beneath the 22.3%.
Yeah.
So when we look at a summary of findings table, we take an assumed risk in the control group and base all our calculations on that. So you're quite right that some of those studies will have had a different rate of diarrhea in the control group. But once we've done the meta-analysis and we've calculated the relative risk, we have to apply that relative risk to an assumed rate. So what is shown in the table will usually be sort of mean effect in the control group across all of those groups. But sometimes you will see a different absolute risk and how that translates into a different risk in the intervention group. For example, if you were treating a group of children who had a very low rate of diarrhea, perhaps only 5%, then that relative risk of 0.41 would translate into maybe a 2% risk in the treated group. Whereas if you had a higher rate in the control group, it would translate into higher numbers. So for the purpose of summary of findings tables, we assume a rate in the control group. And that's often, as I say, either the mean or the median of the rates in the different studies. And then all the other effects are calculated from that. So that's why the confidence interval isn't shown. Great, so I'll come back to the slide, and we've had some good comments through. Brilliant, thank you. So follow-up time is not shown quite right. Minimally important difference, excellent. I'm going to cover that in one of our slides in a minute. And somebody has talked about the study population, who is this included in these studies, and the indication of the certainty of the evidence, excellent. So we talked about the grade approach, and there's not much indication here of the certainty. Good, an outcome searched for but not identified in the literature. Excellent, important to be transparent about what you're looking for. Perfect, so lots of things have come up and all really good points. I'm going to show you a few things on this slide that I think we need to know more about, some of which overlap with the ones that you've already explained. So the first thing that strikes me is this discussion of no significant difference, and we're going to have a talk slightly about the use of this terminology, no significant difference, and what it means. Then we're going to talk about minimally important differences, as someone has raised, and how to interpret that in different scales. A little bit about relative risks and absolute risks, and then the absence of data. So the first thing I want to talk to you about is the use of this term statistically significant, which we're all familiar with from school years and beyond. The idea that statistical significance is some kind of black and white, yes or no answer, magically results are statistically significant or not. And the purpose of this slide is really twofold: to show you and encourage you to think a bit more broadly about the data that you see, rather than just whether or not something is statistically significant. And secondly, to remind you that just because a result is not statistically significant, it doesn't mean there is no effect. So if we have a look at this forest plot here, many of you will be familiar with forest plots, but for those who are not, this is a frequent way of displaying the results from a meta-analysis. So you can see in the plot here on the left-hand side, all of the studies that have gone into the analysis will have a separate line. For this analysis, we've just got a single study, study number 1. And over to the right-hand side of the slide, you see the point estimate from that study represented as the blue box and the confidence interval represented as lines either side of it. Now, because this single study is the only one included in this meta-analysis, the result for the overall meta-analysis is identical to that from the same study. And that's that there was an odds ratio of 0.63 with a range from 0.27 to 1.48. You can see just at the bottom to the left-hand side of that plot, it says test for overall effect with a Z-score and then a p-value of 0.29. By conventional terms, not a statistically significant result. However, we need to look a bit more broadly. Don't just think about whether this is yes or no statistically significant. Have a look, what's the direction of the effect? Although the confidence intervals are wide and they overlap 1, so they overlap unity, we can't be sure there's an effect, but look at which side of the line that treatment falls on, and it clearly falls on the favouring experimental line. And you can see as we add more studies, if we have 3 more studies, all of which individually have the same result, suddenly our meta-analysis result becomes significant, and we can see that the odds ratio clearly favours the experimental treatment. So when you're looking at the results, I'd really encourage you not just to think about, is this a significant result or not, but look a bit more widely as to what is the point estimate, what's the confidence interval around that. And that will all help you when using these results in your day-to-day practice. Then a slide to think about the absence of evidence. So this is often seen in an abstract. No studies reported adverse effects of the intervention. And it's a pet hate of mine because I find it very difficult to interpret this myself as a user. So if we think about this logically, this sentence could relate to one of many scenarios, but the 2 extremes being every single study in our review looked for adverse effects and nobody found any. Right to the other end of the spectrum, which is that none of the studies in our review even bothered to consider adverse effects, and so nobody's reported anything. So always be wary when you see an absence of evidence and think about what is the data that's gone into this. Are there any data at all, or are there simply no data? Because it makes a big difference in how you interpret the findings. And the slide before, somebody mentioned about important changes. And I think as clinicians, we're very familiar with certain scales, things that you measure in your day-to-day clinical practice, blood pressure, hemoglobin levels, and you develop a sort of intuitive sense as to what's an important change in those outcomes. But in systematic reviews, we are often using scales or measurement scales that are not so familiar to us, things that measure perhaps pain scales or quality of life. And the interpretation of that data is really critical on both the length of that scale and what is an important difference on that scale for a patient. So you can see on the slide here, the second example of a mean change in pain being 0.6 units lower. Well, obviously, if that pain scale was from 0 to 1, 0.6 units may be a very important change. Whereas if that pain scale is 0 to 100, it's not clear whether that's a noticeable change at all. So this idea of a small change on a scale which is noticeably beneficial to patients is known as the minimally important difference, or the MID. As an aside, it used to be known as the minimal clinically important difference, but there's a move against that terminology because, of course, this is talking about what's important to me as a patient rather than what's important to us as clinicians. So the minimally important difference is the smallest difference in score of the domain of interest which patients see as beneficial. And it's really crucial to interpret any data on a scale in the light of that minimally important difference.
Katie, just we're making good progress in terms of time. So just can I just suggest we just digress, or at least just focus on something here just for a second, which is if there is a minimally important clinical difference, you could do in a study what Katie's just shown. You could measure the mean difference, and you could find out if the mean difference was greater than the minimally important difference. So let's say the minimally important difference is 5, the mean difference in your study is 6. You say, yes, that's great. It looks like this is worthwhile. But of course, the problem with the mean is it's the mean of all the different participants. Some people might have had a very, very big scores, big changes, some very small. So an alternative, if you know what your minimally important difference is to actually look at the proportion of participants in the study that have achieved that minimally important difference or greater. Because I think that what most patients want to know with a treatment is, what's the chance, doctor, of me being better? And if I am better, how much better am I going to be? If we define being better by achieving a certain minimally important difference, surely then it's better to actually measure the proportion of patients in a trial who achieve at the very least that minimally important difference. Katie, what do you think there's some merit in that?
Yeah, I totally agree. It's a real issue when you don't have a minimally important difference. But if you do have one, then I agree. As a patient, the question is, do I get over that line? Do I notice an important difference to me or not? Rather than what extent, how much do I benefit from this treatment? Getting over a threshold and having a successful intervention is probably much more important. Great. I'll move on to our last couple of slides. The first of these is about measuring risk and how we look at risk and think about risk. Now, as you saw from the summary of findings tables, there are different ways of presenting measures of risk. Absolute risk, the actual numbers of people at risk, or relative risk. And in Cochrane Reviews for your meta-analysis, often that's based on a relative effect. So risk ratios, odds ratios, and hazard ratios. And all of these are showing the effect comparing one group to another. But the difficulty with looking at relative effects is that they can over-egg the pudding, if you like, and you appear to have a much more risk than you would if you look at the absolute effects. So let me show you an example of a misleading relative effect. Here we have a conclusion. The occurrence of sore throat was double in the treatment group, a relative risk of 2, with a confidence interval that supports that. So this, as a patient, might feel quite daunting. You know, oh, my chance of a sore throat is really double. But actually, when you look at the absolute effects in these groups, really the numbers who got a sore throat were quite small. So for example, here, the placebo group had a rate of 50 per 100,000 compared to a treatment group, 100 per 100,000. Yes, the relative risk is double, but the absolute effect is small. And if other aspects of the treatment were beneficial, perhaps it's a very successful treatment from a clinical point of view, it's low cost, it's easy to use, then probably the benefits of taking this treatment would outweigh that risk, even though the relative risk is double.
Katie, just before we go on, one of the things in the previous slide, if you could go back 2 slides, you talked about odds ratios there. And I have a question which I'd like someone to put in the chat or in the Q&A. If I have a 6-sided dice with the dots 1 to 6 or the numbers 1 to 6, what are the odds of me throwing a 6? I've got a 6-sided dice, normal dice. It's not biased in any way. It's a normal one you'd play a game with, playing Monopoly. You throw it. What are the odds of throwing a 6? Oh, someone's done something. The answer is 1 in 6. Sean, that's great. I'm delighted you've answered that, because that's what everybody says, but it's the wrong answer. So why is it the wrong answer? The risk of throwing a 6 is 1 in 6. The chance of throwing a 6 is 1 in 6. But if you think about horse racing, if any of you ever see it on the television, what do you notice? It'll say in a horse race, the odds of Red Rum winning this race are 100 to 1. So the odds are the chance of one thing happening compared to the chance of the other things. So the odds of throwing a 6 are 1 to 5. The chance of throwing a 6 is 1 in 6. Toss a coin, the odds of a head is 1 to 1. The chance of the tail, the chance of the head. The risk of throwing a head is 1 out of 2. So mathematically, odds and risks are slightly different. I mentioned this partly because I want you to not worry about it. Odds ratios are mathematically required for some of the maths that underpins systematic review and meta-analysis. But unless you're a consummate gambler and go to horse racing every weekend, most people and most patients don't think in terms of odds. So bear in mind that odds and risk are not exactly the same, but most people think in terms of risk or chance. And so it's just something to bear in mind. And, yes, so someone's put there 1 in 5. It's not 1 in 5, it's 1 to 5. So the odds are 1 to 5. The risk is 1 in or 1 over 6. Don't worry about it, but just bear in mind that they're different. And if you are a gambler yourself and you're talking to a gambler as your patient, then I'm sure you can have a nice chat about the odds of the effect of the treatment. But otherwise, just stick to risk. Thanks, Katie.
Thanks, Martin. Brilliant. So that brings us nicely to our summing up, really, of the session. So in conclusion, a few things to try and bear in mind and think about when you're interpreting data from the reviews. So the first thing I'd encourage you to do is think about what's the actual size of the effect. How big a difference did we find? Not focusing on statistical significance, but what were the numbers that they reported? What was the confidence interval around that? And when we're looking at measures of risk, as Martin was just talking about, not focusing solely on the odds ratio, the relative risk, but looking at how many people actually had the problem. Is this a common problem? Is it a rare outcome? Secondly, to think about, is this an important change? What matters to patients? How much of a change on that scale will be beneficial to them? And is the effect that you're seeing actually a noticeable effect for patients or not? And finally, and importantly, all the way through, thinking about the certainty of the evidence. Is this the sort of conclusion which is going to change as new evidence emerges over the coming months and years? Or is this a robust finding which you feel confident to use in your clinical practice?
Katie, just before you move on, let me just there's something about this which when you and I looked at the slides, we didn't really think about, but which just came to me, and it's in that middle statement. When you're thinking if it's an important change or an important benefit, you're always saying compared to what? And it's compared to whatever the adverse effects are. So you always have to balance the benefits and the harms. So is it an important benefit compared to the alternative, which might be no treatment, perhaps it is in a study, or it might be, but also even if the comparator is no treatment, if you've demonstrated adverse effects of the intervention, you've got two things to compare: the potential benefit, the change, and the actual cost to the patient in terms of adverse effect. There's also a wider issue about the cost in a societal terms, because sometimes when you're looking at a review, you might have a small benefit of a new treatment, but financially the cost might be enormous. Or in terms of the trouble it causes the patient, it might be enormous. Or in terms of the requirements of the health system to deliver that care, it might be enormous. So the benefit, the size of it, the importance of it, always has to be put in the context of the sort of disbenefits, if you can call them that, or the adverse effects.
Excellent. And that brings us to our final slide, which is just to say thank you very much, and we're happy to take any questions.
Thank you both for that really interesting talk. I've certainly learned a lot during my fellowship on interpreting things, and what you mentioned about the kind of grade and the absence of evidence and stuff that I've, took a while for me to start getting my head around. So for everyone listening, if you've got any question and answers, please put them in the Q&A panel. We don't have anything yet, so I suppose my question is, how do you still feel strongly about having the numbers of trials and numbers of participants in abstracts, and how does that kind of influence your decision making on interpretation?
So I'll give you my view, Becky. I don't feel that strongly about it, actually, because that should have come into the certainty of the evidence. So when you're looking at the precision of the estimates and ranking your certainty of the evidence accordingly, when you've got few trials, few participants, the evidence is going to be less precise, and so the certainty is going to come down. I suppose as a reader, it's fairly helpful to get some intuitive feel as to, is this one small study or are these 10 huge studies? But I think using the grade approach, it gives you some information about that without necessarily needing to write out the words.
I think you should put the numbers in for the reasons really that Katie was alluding to. Although in truth, the grade rating does sort of include that information. I think people expect to see how many trials, how many participants, and there is a difference between one trial with 10,000 participants and 10 trials with 10 or 100 trials with 10,000 participants, isn't there? So I think people do expect to see that. Could I make a, so, well, until this, so we get some more questions, could I make a comment about absence of evidence as well? We talked about absence of evidence in one sense in the talk. We talked about it in the sense of not always knowing when people are talking about adverse events, whether people actually looked for them or not, or they looked and didn't find any, or they didn't bother looking and that's why they didn't find any. There's another sense in which we often talk about absence of evidence isn't evidence of absence. And that's when people often write in abstracts, there was no evidence that, or there was evidence that something did not work. And those statements are often incorrect. The most we can often say is that we found no evidence of an effect. It's like the usual philosophical thing of not being able to prove a negative. And it's very important. We often, when we're reviewing abstracts in draft form and trying to improve them, one of the improvements we often have to make is making sure that people say there was no evidence of an effect, rather than saying there was evidence of no effect. Do you see that there's a subtle difference between, an important difference between those? Katie, you must have seen that in abstracts that you've read, yeah?
Yes, yeah, definitely. And I think part of it also comes down to the statistical significance too, that people are looking at that as their guide as to whether there is an effect or whether there's not an effect. But actually setting out to prove that there is no difference between two treatments is quite a different thing to setting out to investigate whether there is a difference.
I suppose that kind of then brings up the, the absence of p-values often in Cochrane abstracts and even in the review as a whole. Yeah, have you got views on that, or not using p-values?
For me, I would say the more information you can give the reader, the better. But I think the steer from Cochrane very much is to look at the effect size, report a confidence interval, to try and stop people focusing on this issue of, is this a significant change or is it not a significant change? I think their steer is probably not to never use them, but if we're going to report a p-value, we tend to report it exactly. So you won't see p was less than 0.05. What you should see is p was 0.0236 or similar.
I've been taught to have antibodies against p-values, and they've reached almost anaphylactic proportions now as I've got older, I have to say. I mean, the confidence interval tells you something about, is another way of telling the certainty, of the evidence. And I think the confidence interval is more useful, really. Yeah, I mean, and p-values aren't magical in any way. And this idea that p less than 0.05 has been chosen as the cutoff, I mean, it's a subjective decision, isn't it? Someone decided at some point that was that. Well, it's the same with the confidence interval. A decision has been made that 95% confidence is the amount of confidence that we want to have. But of course, that leaves a 5% chance always that we're wrong anyway when we look at these data using that sort of interval thing. Oh, this note in the chat there say, someone's put my article about invisible unicorns up there about,
And Katie, well, both you mentioned, another way of looking at data is to kind of set your, your minimum important difference is to say how many people have reached that. And I was just wondering what that would look like in the review in terms of, what would the authors be doing to be able to change the data so they can answer that question?
So there are ways that you can convert it if the data are reported on a sort of continuous scale. So perhaps you've reported mean blood pressure, and what you're interested in is the mean are the number of people who achieve a certain target blood pressure. Perhaps they get below a systolic of 120 or something. There are ways that you can convert that data, but they require a lot of assumptions. So one of the challenges is that you're always trying to find a way to synthesize the evidence, but also trying to make sure that obviously the data you're reporting are fair and accurate. Ideally, we would look for trialists to report both things. So state, this is the minimally important difference, and these are the number of people who achieved it, and here is the mean difference. And then you can simply choose the data that you need relevant for your outcome in the review. But there are ways of assuming what a mean difference will translate to in terms of the number of people who've achieved a target and converting it between them.
And what this is showing is that, that as a systematic reviewer, you're really hostage to the decisions that the trialists have made. I mean, you only have the trial. Well, you haven't even got the trial data. You've often got the reported aggregated trial data. If you had the individual patient data from every participant in the trial, which sometimes you can get, then you'll be better off able to do it. But it also, I think, raises another point about what outcomes should be measured in trials, and this idea of having a core outcome set, that whatever clinical area those of you on this call are working in, for different conditions and for the evaluation of those conditions, ideally there should be a set of outcomes which patients, clinicians, stakeholders, trialists together have come together and have agreed upon are the most important outcomes of relevance to patients, so that all future trials and therefore all future systematic reviews could revolve around those. I mean, if society, if the medical, well, not the medical fraternity, if society had decided that in elderly hypertensive people, a 5% drop in systolic blood pressure was significant, then that should be the outcome that people look for in trials. But of course, life's not quite as simple as that.